Hello, this video is about the St. Gallen Breast Cancer Conference and the consensus meeting. I'm Thürlimann, one of the co-chairs, and this is Michael Knauer, a colleague of mine. I'm a medical oncologist and he's a surgeon. I'm happy with the conference and the consensus meeting as more than 3,400 delegates participated from more than 90 countries. And we had to change the meeting from a face-to-face meeting to a hybrid meeting and then finally to a fully virtual meeting, which was quite a challenge and a fair piece of work, as you can imagine. So my thanks that it was able to run so smoothly goes to the faculty and all the organizers working behind the scene. And thanks again also. It is for the first time that we honored Aaron Goldhirsch, who died sadly. And we conducted an Aaron Goldhirsch memorial lecture. Aaron Goldhirsch was the driver of the conference, and he did the critical step, we will come back to that, from risk-adapted therapies to targeted therapies, giving endocrine responsiveness a priority, also as a criterion for chemotherapy. We will come back to that with the Ponder X and the Taylor X results and in the multi-gene signatures. We had also the largest expert panel ever with 60 experts, and we have also new experts, actually 21 new experts since 2019 and 17, with an increasing number of female members reflecting the reality of breast cancer care today. Now let's turn to loco-regional treatment. And Michael, would you please start?
Yes, thank you, Beat. My name is Michael Knauer. I'm a breast surgeon at St. Gallen. And we had very interesting topics about loco-regional therapy. It is evolving, mainly regarding de-escalation of treatment and safety. I think one of the major things is that surgery after neoadjuvant chemotherapy is a matter of debate. What is the extent, what to do with the breast and what to do with the axilla. There were not so many discussions this year regarding surgery of the breast after neoadjuvant chemotherapy, but more what to do with the axilla, with lymph node metastasis. So on one hand, the technique of tailored or targeted axillary surgery, that is taking out just the affected nodes or the previously affected nodes to look if the patient is really node negative after neoadjuvant chemotherapy, is more and more common and was also endorsed by the panel quite strongly, I would say. And the other thing that came into my mind is that if after node positive patients had neoadjuvant chemotherapy and there's just a little bit left in one of the axillary nodes, what we call micrometastasis or isolated tumor cells, that this is probably not always a reason to go back to surgery and do a secondary axillary dissection. Maybe if you know it at the first operations, you would do it, but it's also an option to go for radiotherapy instead of additional surgery in these patients. Regarding radiotherapy, there were major changes, I would say. For example, hypofractionation. Hypofractionation is, it was not called anymore hypofractionation, it was called the new gold standard. And this is really a change because people were also quite, let's say, hesitant or careful to look if there is really not more toxicity for these patients. But now if we look at all these votes, even for post-mastectomy radiotherapy and for regional node irradiation, it was really endorsed that the lower fractions, the 15 fractions is the new standard and we don't have to go for 25 fractions anymore.
I can add here that Philip Portmans, who was the award winner this year from the St. Gallen Breast Cancer Award, he gave an excellent lecture, added to this question in the elderly that even the now new gold standard might be replaced, probably already next time, to the fast forward regimen in elderly, which needs only 5 fractions, and then patients are done with radiotherapy. And he added that in the respective studies, the toxicity for those regimens, very short regimens, are even lower than the currently accepted regimen, and not to speak about, he said, the historical regimen.
Old-fashioned.
Old-fashioned even. So I think we have enough confidence that we can make this step, and we hope that this is also be implemented and that patients can benefit from it, as radiotherapy resources are limited in many countries.
Yeah. One of the next question was partial breast irradiation, and this can be done in certain circumstances. There are guidelines for this, but the panel clearly voted that outside of this clear indication, it should not be a standard. In some cases, radiotherapy could even be omitted. In elderly patients with low-grade tumors below 2.5 centimeters, this was also discussed. And when can we leave away surgery? This was a question. It was interesting.
What I just wanted to ask.
Yeah, because in San Antonio, there have been several studies have been presented, but they were all negative. So the question was, after neoadjuvant chemotherapy, can we do just a biopsy to make sure that we have a complete remission? But we still, up to now, cannot rely on imaging for that, not even on MRI. And we cannot rely on core biopsies or even vacuum-assisted biopsies to clearly say this patient has a complete remission and we can skip surgery. And we can discuss about comorbidities, we can discuss about age, that we can leave away at least axillary staging surgery in certain circumstances, but this was clearly not a standard.
Well, I think the panel was quite reluctant to go a step forward in the breast, but based on old studies with a long follow-up, the issue is a little bit different in, let's say, elderly but fit patients related to axilla. Can you elaborate a little bit? Can we avoid axillary surgery at all in some patient populations, even in fit patient population, and with long life expectancy?
Yeah, I think this will be the case, because in special circumstances of low risk, etc., the risk of axillary involvement is very low. And even if so, there is systemic treatment, there's radiotherapy, but these studies are still ongoing. So they have finished accrual, but the results have not been presented. So it's not a clear indication for a large group of patients, but of course, in certain circumstances, subgroups, we do this already today. The last topic I would go a little bit into detail is probably that reoperation and re-irradiation. So we see that local or loco-regional recurrences have gone down a lot. So the numbers that some of us still have in mind of 20% local recurrence rates without this treatment or that treatment is just not true anymore. We are facing local recurrence rates of 2 or 3% in 10 years, for example. But some patients will recur. And what to do if a breast-conserving treatment has been done and now a second, let's say, small cancer appears in the same breast again. And up to, let's say, this year or last year, everybody said, well, go for a mastectomy, it's safe. But we have some experience, but not large prospective trials, where we can look, can re-irradiation be done, or can a second lumpectomy, a breast-conserving surgery, can also be done? And probably in some of these circumstances, this is an option, but on an individual basis to discuss with the patient.